So, welcome to the speaker series for Ohio University REU program and the RISE program at Nationwide Children's Hospital, directed by Dr. Fran Wims and Dr. Eric Youngston, respectively. I want to welcome Dr. Jill Einreich-May, who appreciate joining us today. She's a professor of psychology and the associate chair of the Department of Psychology at the University of Miami. And for clarity's sake, that's not Miami University in Ohio. Miami University in Ohio started in 1809, which was more than 100 years earlier than the University of Miami started. Although it wouldn't fare well for Miami University to play University of Miami in football, but
I was just going to say.
It happened recently.
It did?
Yeah.
Oh, wow. Well,
And
that wasn't pretty.
Did it go about as we expected?
It did.
Yeah, I would imagine so. She's also the director of the Child and Adolescent Mood and Anxiety Treatment Program, and her work focuses on novel treatment approaches for emotional disorders in youth, etiology and measurement of youth anxiety, clinician training, and dissemination of evidence-based treatments for children and adolescents. As we normally do, Jill will give a talk for about the first 40 minutes or so, and then we'll save the rest of the time for questions and discussion, including everything about the content she presented, as well as about professional development, career moves, and how she came to the point she is today, why she chose to do what she's doing, advice she gives to undergraduate and graduate students, all that kind of stuff. And we end at 2:45. So thank you very much, Jill, and I'll turn it over to you.
Well, thank you so much for having me. I feel really honored to kind of be bringing up the rear on your speaker series for the summer, and hope that
cleanup.
Yeah, batting cleanup. I'm hoping that I've kind of thought about your series, and I wanted to kind of frame the talk a little bit about my own thought evolution over time, in terms of at least how I have been viewing the field of child interventions research, where there are some limitations, and how I've been trying to kind of slowly but surely pivot my own research to better fit the needs of youth and families in community settings, hence kind of the title of my talk here. I am going to be talking about the Unified Protocols for Transdiagnostic Treatment of Emotional Disorders in Children and Adolescents, which is something that I have a few conflicts of interest with. So just to mention that I do make a royalty from the sales of the treatment manual and workbooks, and get paid for clinical trainings and consultation and implementation support. And this is also the focus, as I'll talk about today, of a lot of the research that I do. And some of that is funded by places like the National Institutes of Health, the Institute of Education Sciences. I'm going to talk about a project specifically from IES today, as well as foundations like the Batchelor Foundation and a local children's services organization that is funded by referendum from Miami-Dade County to pay for evidence-based services here, called the Children's Trust. So that some of that work will be discussed here today. So I'm going to hope in this like 40-ish minutes to take you really quickly through a little bit of background on these treatments, why I kind of started to look at the efficacy and the development of these approaches in the first place, how we pivoted to effectiveness-oriented research, or research that was really about sort of how well might these treatments work in community settings, and then how they've been further modified and adapted over time to address issues of equity and access in particular. And then I'll give you an example of a hybrid effectiveness implementation study that we're doing right now to adapt this treatment for use in what they call Title I schools, particularly high schools here in Miami-Dade County. So I think you're probably aware that youth mental health concerns are a problem. So I probably don't need to convince you on this topic. But particularly during the pandemic, we certainly saw an incredible spike in problems like anxiety and depression that was documented pretty vigorously, and also discussed quite a bit in the media. And you know we can agree that these problems have really been on the rise, but they were quite prevalent concerns to begin with. And so, the fact that these were the problems we were seeing a lot more of, given the types of experiences like loneliness and isolation that were going on, ongoing uncertainty, also makes a lot of sense logically. We also know this is the modal age of onset for these problems is around middle childhood, around age 11. And although we kind of think about problems like anxiety and depression and related concerns like OCD, sometimes as internalizing concerns, meaning that they don't have the obvious, sometimes behavioral interference in places like classrooms and other settings, they do cause a lot of impairment for youth in terms of normal developmental routines, building friendships, school-related academic outcomes, things like that. And we know that without effective treatment, that these things don't just go away. It may seem like sometimes the type of anxiety changes over time, or there might be some waxing and waning of symptoms, but we know that these things tend to be relatively stable and predictive of more negative outcomes, unfortunately, like risk behaviors, substance use. And other, more serious, other serious concerns like suicidal behavior. And of course, given that there is a large need and a rising need for treatment of these types of concerns, you would sort of assume that one of our main priorities as a society would be to train a workforce of substantial nature to disseminate any of the really quite numerous evidence-based psychotherapy manuals that have been developed over the last 50 years. All of these wonderful manuals that I'm showing you here contain active mechanistic elements of change and have strategies like exposure therapy or problem-solving techniques that are really acutely designed to help children in need with these particular concerns. Most of this treatment development, though, has historically focused on kind of one type of problem. Like there's a manual here that I wrote with Donna Pincus and Sarah Mattis for treatment of panic specifically, or sometimes like a narrow band or a cluster of problems, like a group of anxiety problems, as you might see with like the coping cat, for example. And that makes a lot of sense from an internal validity perspective, meaning that you could see symptoms from like a single disorder or a small group of disorders change from the beginning of treatment to the end of treatment pretty reliably. However, we know that most organizations probably just lack the funds to train on any evidence-based treatment consistently. So just picking one problem-specific approach to spend that funds and capital on, as good as the efficacy and maybe not the effectiveness data, we'll come back to that, might be for these manuals, probably doesn't use training time effectively. And it may not actually represent how most youth and, present, or most families present in community settings. And of course, more bad news. The scope of our current mental health crisis, might be particularly alarming as well, because as Alan Kasdan reflected in his seminal paper on this topic pre-pandemic in 2019, we know that worldwide, the vast majority of children and adolescents in need of mental health services get no treatment, particularly not an evidence-based psychotherapy for anxiety and depression. And there are a lot of barriers associated with these concerns, and I'm not addressing all of those with my treatment nor in general, but I think that in this presentation today, but I do want to just highlight a couple of them. One obviously key barrier is that the dominant model of delivering a type of psychosocial interventions like the ones we're going to be talking about today is that they are, often one-to-one in-person treatments or on telehealth with a trained mental health professional provided in a clinic setting, and that model is very costly. And that greatly limits the scale and reach of effective psychosocial interventions. And also maybe doesn't recognize that children are clustered in other places like schools or other high traffic community settings that might be more effective to target. And even if we thought that all of our evidence-based treatment models could reach youth using those kinds of methods, the research shows that when we try to translate our evidence-based treatments to non-research settings, they do show a demonstrable kind of drop in potency, sometimes below that what we would expect for no treatment, or a placebo condition, and definitely do not always outperform the treatment as usual that's provided in these community settings. That's something that's been kind of famously termed the voltage drop from evidence-based therapy efficacy to effectiveness. And unfortunately, we know that also there are training issues here in the United States and other places where many people who are receiving training in psychotherapy don't get training in the evidence-based therapy models that do exist. So these are sort of combining with other concerns to really, stymie the receipt of these evidence-based treatments to children who are in need. I do want to touch on just briefly like two other barriers. I mean, one is that, even if we had enough providers and we were training all of them to do these treatments very acutely, some could argue that, the focus of our treatments, our evidence-based treatments are for children with anxiety and depression are kind of derived from an adult focused model of psychopathology that's kind of based on this concept of a core intrapersonal dysfunction, meaning that it is something wrong that within the child that needs to be addressed, a kind of a deficit model, if you will. And increasingly, researchers have called for us to consider the more contextual impacts of issues like racism, discrimination, bias, and kind of reconsider our models and our assumptions within our models of treatment. And of course, even if you were to create a new therapy today to try to address all of these concerns, we have other issues with getting our treatments out there quickly. The sort of innovation pipeline to getting these treatments to children, unfortunately, is extremely slow. So I'm not going to solve all those problems today, like I said, but they are thoughts that are in my head when I'm thinking about what to do next. And so I wanted to kind of present, I'm thinking about these kind of issues more broadly as I'm trying to evolve my own treatment research to better and better address some of these concerns. But the central thesis behind some of my research is kind of transdiagnostic approach to youth psychotherapy in any way modulate some of these limitations to the receipt of good, equitable care for youth in the community and more broadly. And a transdiagnostic approach, meaning like treating more than one problem across different domains, for youth emotional disorders, at least, makes a lot of sense logically. We know that the vast majority of youth that present for care have multiple overlapping concerns, not just one concern. And just considering anxiety and depression alone for a moment, anxiety and depression in youth share genetic, neurobiological, environmental risk factors. And at the symptom level, as evidence here by parent and child reported partial correlation networks, this is fancy network analysis, using the SCARED, which is the child anxiety measure, and the mood and feelings questionnaire, which is the depression measure, with about 467 youth around age 12 that participated in research in my clinic at the University of Miami on the UPC and UPA. What we see here is that depression and anxiety symptoms are highly intercorrelated. That's regardless of whether the caregiver told us that or the child told us that, although symptoms to symptom relationships are stronger between anxiety clusters or facets of anxiety than between anxiety and depression. To be honest, I think a transdiagnostic approach just makes sense logically. I'm a very pragmatic kind of person when it comes to therapy. And when I was thinking about how to developing this intervention, it was really partially because when I was working at the Center for Anxiety and Related Disorders at Boston University, that I had all of these great treatment manuals on my wall, and I was pulling pieces of them for every client that I had in front of me. And that wasn't actually that I kind of used to call it my Franken manual. And it wasn't that hard to kind of create that because the insides of those treatments were largely similar. And particularly those that had kind of a cognitive behavioral or contextual behavioral sort of focus to them. So most of these treatments contain things like learning how to identify and label your emotional experience, learning how your experience of emotion impacts your behavioral choices, sometimes very automatically prompting things like avoidance behavior, escape behavior, aggression, compulsions. And then the treatment strategies for that, aside from those more educational and labeling kinds of actions, are, kind of cluster into 3 areas. One, cognitive strategies, which, depending on which manual you pull, might look a little bit different from one another. Some might focus on differing aspects of cognitive flexibility, trying to sort of understand that more than one thing could be true about a particular situation, or being mindfully aware, or testing your assumptions about what could happen in a given situation. And then a litany of behavioral or opposite action, as Marsha Linehan refers to them, strategies, where maybe you are trying out a very opposite or different behavior from the one that the emotion is trying to make you do in a given situation, and learn whether or not you can cope with that, whether it helps resolve some of the distress that you're having in these situations. And then a third component of caregiver strategies. This is probably where manuals differ the most between one another. Some have just a slight focus on caregiver components, where maybe you're meeting briefly with a parent to talk about how the last session went, and to give a little bit of information about homework, or some education about the strategy you're using. And then others where the entire focus is on teaching the caregiver mechanistically something important that would lead to symptom change in the child. Ellie Leibowitz's SPACE approach, for example, is really focused on training caregivers to modify their own, what they call, accommodation behaviors in the context of a child who's anxious and distressed. And actually, they don't meet with the child at all during that treatment. I certainly want to acknowledge we're not the only game in town when it comes to transdiagnostic or multi-diagnostic approaches. Researchers like the very eminent John Weiss and Bruce Torpeda have taken different but very similar approaches in some ways to this question, as I have. And, in terms of what I've done in response to needs for a treatment that address core processes that might be underlying commonly occurring emotional problems, and the overarching similarity of techniques for these conditions, we've developed an intervention for youth that focuses on cross-cutting what we might think of as core difficulties or core dysfunctions in emotional problems. And instead of focusing
Jill,
on just,
Jill,
yeah,
can I interrupt you? I think
sure.
the slides might be lagging. We're on the manuals do not differ much by disorder slide.
But I don't mind, because I'm trying to download the articles that you're suggesting.
Is it advancing now to the UPC?
Oh yeah, now we're on the UP.
Okay, that's
the
where
universal
I am.
protocol. Okay.
Yeah, I'll try, maybe I'm going too fast. I don't know why it's lagging, I'm sorry. Okay, anyway, so, the way we get away with this, this transdiagnostic approach, is that instead of focusing on just one type of emotion or just situations that fit within one diagnostic category, the UPC and UPA focus on the experience of strong emotions more broadly, and the youth and caregivers' relationships to them. And it does this using predominantly a modular structure, although we do have a version for children that is run as a group as well, which is a little bit more structured, and a lot of flexibility. So when we present these things, we're presenting them as a singular set of techniques, but people can also certainly pick and choose what they want to use from those techniques to be flexible with any given child. I'm not going to get into into the treatment in too much more detail today because I want to focus on the research that we've done about it. But I do want to say that just in general, the UPC and UPA consist of 8 core treatment components. I'm not showing here our motivational / self-monitoring module and our review consolidation module that are thought to engage mechanistic putative targets, specifically the aversive reaction that one has to frequently occurring negative emotion. And we measure that with things like measures of distress tolerance and avoidance. And we think that if those targets move, although we're just publishing a paper where it didn't work the way that we thought it would. but let's just say in theory, the movement on these targets should lead to improvements in emotional disorder symptoms. It's also maybe the case that for all anxiety and depressive disorders, movement on those targets, regardless of the treatment, operate through change in these mechanisms. Please note, generally speaking, that these modules have kind of 2 different developmentally sensitive versions of their administration. We have one for children, one for adolescents, and there's a much more significant caregiver component in the child version as well. So how did I get here? Well, I was working at Boston University, like I mentioned, and I got what they called a K Award, which is a Career Development Award, while I was there to develop the Unified Protocol for Adolescents. And that's like a mentored research award. We did a series of early trials to iteratively develop the treatment. So we did a multiple baseline design study. We did some single case work as well to further refine. We did an open trial where we just gave everybody the Unified Protocol for Adolescents. And then I moved to the University of Miami and opened up a little research clinic. And with one research assistant and one graduate student, we somehow ran a very small randomized control trial as the latter part of my K Award here at Miami. And in this study, we were comparing the UPA kind of to nothing. So basically comparing it to a waitlist condition. When NIH gave us this funding, they were really very specific that they wanted us not to exclude a lot of adolescents from this sample. So we had kids that had non-suicidal self-injury, who had suicidal behavior, who were quite depressed in this sample. And we randomized ultimately 51 adolescents to either get an 8-week waitlist or 16 weeks of the Unified Protocol for Adolescents in a fixed session way. So we didn't vary it in terms of the order of components in this particular trial. And at 8 weeks, when we did our primary comparison, what we found is that according to clinician reports, the UPA was outperforming the waitlist condition. But according to parent and child reports, we still were not sure yet. They were not significantly different from one another. However, when we finished the waitlist, we had all of those people participate in the UPA, and they all got the treatment. And these are very sophisticated analyses. They're called the multi-level modeling analyses, MMLM, where we basically looked over time. We saw across all measures that people had a pretty large effective treatment, anywhere from a Cohen's D of 1 to 2 on things like self-report measures of anxiety life interference, depression, and also clinician ratings. And these seem to slightly improve even more when we went out to 6-month follow-up. Around the same time, I had a wonderful graduate student named Emily Bialik, who's now a professor at University of Michigan, and another graduate student named Sarah Kennedy, who's a professor at the University of Colorado School of Medicine now, both pictured here. And Emily and I got approached by a summer camp on the University of Miami campus that was doing wellness programming and asked us if we would want to do something related to anxiety or depression for the summer camp. And Emily and I had been talking about developing the UPC, which we call emotion detectives, in-house, and whether we should try it out with this camp instead, which was a hoot, doing a universal prevention in a camp setting. you know, we it worked well. We published a paper on it. I would say that it was a challenge. Those kids were not there to do exposure therapy. Uh, but we learned a lot from it as an initial way of doing the treatment. And we were like, but this might work better as an intervention in a clinic setting. But we had gotten used to doing it as a group intervention at that point. So we kind of stuck with the group intervention model for this. And we developed both caregiver and child materials for the UPC. And this is just a very small randomized trial that was part of Sarah Kennedy's dissertation, where we were comparing this to another group CBT approach called Cool Kids that was developed by Ron Rapay and colleagues in Australia. And there were only 47 youth in this trial, so you can't really take a lot from it. But I will say that there probably could have been 470 youth in this trial, and we still probably wouldn't have seen a difference in anxiety at the post-treatment point. Both treatments really effectively addressed anxiety at the levels of response that we typically see for CBT for anxiety. So in that kind of 60% of youth sort of showing, you know, kind of the remission rates that we would expect at post-treatment. What was interesting were some slight discrepancies that really served as hypotheses for other trials we later did. I don't have time to get into all of them, but basically we started to see some movement in things like sadness dysregulation in this sample in a differential way, as well as something that has I think of myself as a really hardcore behaviorist. And so it always strikes me as really interesting when we see like our cognitive variables being so potent in these interventions. And I just have to take it on the chin that I guess this treatment does a good job of helping people being more flexible in their thinking. And that's something that we've seen kind of again and again in this trial. And a lot of these kids were doing well, at least in the completer sample when we went to follow-up time points. So that was something as well that we were really interested in seeing more about. But these were all trials that were done in my small little research clinic. It's grown a lot, but still, in the University of Miami. So that was a really privileged sample of families who were able to find us at the University of Miami. We live in it's University of Miami. If you've never been there, is in a very wealthy area of Miami called Coral Gables. And it is predominantly Hispanic or Latinx community, but it is still predominantly white as well and very high income. So we really wanted to try to start thinking about the youth who needed this treatment the most and how we could get these treatments into the hands of community practitioners more quickly. So we we got another grant from the National Institute of Health, an R01 level study we called the COMET study. And this was an effectiveness trial that was run with my collaborators and, you know, academic superstars, Mandy Jensen Doss and Golda Ginsberg at the University, who was at the University of Connecticut. Mandy's with me at the University of Miami. And in this trial, we were asking a particular question. We were asking a question about community mental health centers and whether if we randomized youth to receive treatment as usual that they would get normally from their clinic versus a combination of measurement-based care strategies with or without the unified protocol for adolescents, whether we would see some differential impact of either adding that very systematic assessment process that comes with measurement-based care and or the additional evidence-based treatment on top of that. I will say that that was a lot of burden on the clinicians. This trial is endlessly interesting. I could talk about it for the next 45 minutes. Was very difficult to run. We had originally anticipated something like 9 clinics and, you know, like 20-ish, 21 providers. And we ended up having 174 clinicians treating only 193 youth across 19 community mental health clinics in the 5 years. And there are a lot of reasons for this. There were very high turnover of these master's level professionals in these community settings. Anybody who was really great as a clinician in our trial often got promoted to being a supervisor. And then, so on average, people only saw one case in the trial. So we had to constantly retrain people to be in this study. So long story short, I'm just going to hop right to the conclusion of this 5-year-long journey that we had with this trial. But basically what we found was that all of the treatments helped children with anxiety and depression. In terms of primary outcomes, there were no differences between the treatments, which is good news, at least amongst what was largely a pretty motivated set of clinicians who, were providing good quality care. That seemed to work well, no matter what type of treatment approach or an assessment support that they had. There were some differences when we looked at secondary outcomes, particularly that both the EPA with the measurement-based care and the measurement-based care alone outperformed the treatment as usual condition with regard to youth-reported measures. So when the youth told us how they were doing, there were some differences, but not between the one that just involved measurement-based care versus adding the EPA. And there was good fidelity to the treatments overall, but we did find that when we translated this to community settings, that people sometimes didn't use some of the great strategies that were in the treatments, like exposure therapy, for example, which we think is such a potent and important part of the treatment. We learned a lot of lessons from this trial, and some that had to do with how we designed the trial. And one of the things that we really learned was that we really needed to partner with these settings, partner with the youth in these settings to really think about how they needed to be meaningfully adapted before we started the trial. We kind of just ran this as though it were an in-house research, clinic study about this treatment, and that I don't think that actually represents how most people would use these treatments in community settings. They would, and so I think we got to sort of the next stage of effectiveness research, and we started partnering a lot more. And one of the trials that started after Common, so we were able to learn the lessons from it, is the ProCare trial, which is a study that is done in Spain with my collaborator, Luis Joaquin Garcia Lopez. And in this trial, it was meant to be actually a school-based trial, but then the pandemic happened. So it ended up all being a telehealth-based study across Spain. They partnered with youth community boards to really identify risk factor behaviors and that children and adolescents were experiencing significantly at that time, and added risk factor modules to the treatment that could act as breakout topics for the adolescents to utilize. And in this trial, what we found is that from an education support condition compared to what they called ProCare, which is the EPA alone for 10 sessions, or the EPA plus the risk factor modules, that adding these risk factor modules enhanced both the regular anxiety and depression effects, and more broadly was a more satisfactory treatment to the youth who were involved. I wish I had more time to play this video because I think it's cool, but I'll just show it to you for like 5 seconds because I know there's a lag.
Did you know that young people are experiencing emotional difficulties more than ever? Nowadays, 400 million young people are estimated to be at risk or suffer from emotional problems. More than 1.5 million are in Spain. This is a serious public health problem. ProCare Plus is the first elective prevention
It's not working. At least on my screen, it wasn't advancing. But they made all of these cool animated videos to disseminate their findings, which I just thought was such a great idea, to have that way of communicating your results in a way that other people like on YouTube might find them, as opposed to necessarily just landing them in a journal. And I just wanted to highlight one other effectiveness trial that just wrapped up. This is one that my colleague Helena Morera, who's at the University of Coimbra, and other colleagues at the University of Lisbon, and I collaborated on together, where we were learning kind of the lessons from the COMET trial, and really wanting to sort of understand when we were going to translate this time the UPC into community clinic and hospital settings, really across Portugal, what kind of pre-implementation work we wanted to do to adapt. And once again, we worked with both clinicians in these settings as well as caregivers and youth, and ended up adapting the treatment, obviously, to Portuguese, but also to just down the type and delivery of the caregiver sessions. So these were mostly caregiver sessions that were done either digitally or by telephone. And then there was a mix of in-person and digital sessions, because in Portugal they had a limit on the number of sessions they could come in person to receive, with, again, in between session clinician support by phone. And here we also had the community clinicians learning with a lead from the study to kind of model the treatment for them initially. And once again, compared to a psychoeducational comparison condition like the ProCare trial, we saw pretty uniformly nice results, fairly large effect sizes for the UPC across all measures of anxiety, depression, life interference, and caregivers as well improved in some mechanistic targets like overprotective behaviors. So I feel like we're getting this effectiveness thing down, with every iteration that we're doing. But we're certainly not the only persons who have been adapting this treatment. I think because it's transdiagnostic, it's been a popular target for people to adapt for a lot of different related emotional problems. In fact, Sarah Kennedy, who I mentioned earlier, and I have written a book for Oxford University Press just detailing the really large number of adaptations that have been made for related emotional and other problem areas, and giving examples. And that this book is actually really nice because it has like little one-page tear-outs that you can use for adapting it for these different problem areas as needed. It's certainly been adapted also for many other types of settings. My colleague in Canada, Gina Dimitropoulos, has done really beautiful work adapting this for residential care for maltreated youth as more of a curriculum. Similarly, it's been incorporated into residential and IOP settings and some other pediatric settings. I'll show you an example of one of these adaptations in a moment. But adaptation also sometimes is about increasing or the availability of the treatment. And during the pandemic, we also worked on a caregiver-only directed version of the treatment in a brief way. This is a lot of data on this slide, but this is a study with Eric Storch at Baylor University. And this COV-TAB variable is COVID-related distress. But I think one thing that I wanted to point out here is that when you do an adaptation like this, I always suggest that people really look at the satisfaction data very closely, because, we took this treatment from 15-week treatment to a 6-session parent only, or caregiver only directed treatment. So nobody is going to come out of there and say, hey, you know what, I got everything I could possibly need out of 6 sessions. But what we did have was the parents saying that they learned new strategies that were helping their child to kind of cope with their emotions, which is really the spark or the step we wanted parents to be able to take during this time, to be able to kind of help their own child, particularly during the pandemic where accessing a therapist might have been particularly difficult. I have a grant from NIH with Jessica Schleider from Northwestern University and 3C Institute, where we've been developing single session intervention modules online of the different components of the UPA. And the idea is going to be that we're going to test this out in the second phase now of the grant, embedded within an EMR, so an electronic medical record at Lurie Children's Hospital, to see whether people who are on wait lists and are not able to receive treatment face-to-face with a person might be able to access care this way. And again, the treatment has been adapted in other important ways to address equity issues, particularly Alana Seeger Van Dyke, who is at Massey University in New Zealand and actually used to be my research assistant way back in the day, undergraduate research assistant, worked with John Pachenkis at Yale during her postdoc to adapt the Unified Protocol for Adolescents to address minority stress, and particularly in LGBTQ plus populations of adolescents. These are just some of the adaptations that she's made to this now group version of the intervention. She has a Career Development Award in New Zealand to test this out with Rainbow Indigenous youth in New Zealand. So we're really excited to see kind of this next phase, but some of the initial research has been promising. Interestingly, there's not a lot of change in the content here. What's changed is the focus on minority stress versus like different emotional problems in the discussion. So very briefly, I'm just going to show you one last study that's actually ongoing right now before I wrap up. And I've taken a lot of inspiration from these collaborators, these many collaborators who were doing such cool work to adapt and implement the treatment. And I was like, I want to do that too. So we have recently launched a hybrid effectiveness implementation study where we're adapting this treatment in schools. Of course, I've mentioned already that we think schools might be an ideal setting for the delivery of these emotion-focused cognitive behavioral components, kind of meeting children where they are. We call this the UP study. And this is actually what we've been calling the treatment itself. I want to acknowledge the other PI on the UP study, which is Dr. Sarah St. George, who's a public health scientist here at the University of Miami. And so the study aims of this this particular trial that's ongoing are to conduct focus group interviews with school community members. As I mentioned, I kind of don't want to do this type of treatment research anymore if we're not engaging with the community that we're going to be serving to try to adapt this treatment to fit the best use in that particular setting. We did a case series to refine the intervention and also did more qualitative work after that. And now we're in the midst of this randomized effectiveness trial where we're comparing UPs to services as usual in a really interesting setting. And we're also analyzing costs and whether it's beneficial from a cost perspective. So the setting that we're working with is called the School Health Initiative. It's a partnership program with Miami-Dade County Public Schools, which is the third largest school district in the United States. This is run by Dr. Lisa Gwynn and Lizzie Polgaron, who are pictured here. It provides integrated, you might think of as pediatric primary care to 12,000 youth per year in Title I schools. We've invested and incorporated this study with the SHI team from the start. So they're members of our investigative team. They're members of our clinical and research team as well. This setting has been incredibly helpful. I've reflected numerous times that I don't think the study would be going anywhere near as well did we not already partner with an organization that had a lot of trust established with the schools already, that was really valued by the schools, that had physical space to run these studies. We didn't have to run into somebody's classroom and take them over because they already had some dedicated space for the clinic and that were already trusted to provide mental health services. Believe it or not, Miami-Dade County, despite how large it is one of those counties that does not provide its own mental health services. It does a little bit, but very little bit. Most of it is referred out to community partner organizations. So the schools that have the School Health Initiative embedded with it are also really excited that they have these clinics there because there's nothing else like it in the county. Most children at other schools, if they have concerns, maybe there's a traveling therapist that can see them at the school, but most of the time they'd have to be referred out. So I don't have time to go through all of the aspects of this trial, but we did learn a lot from our qualitative interviews with these families. I'm sorry, with the caregivers, with the children, with the school professionals. They gave us a lot of direction for our treatment that informed an initial adaptation to UPeace. These are just some of the topics that came up. We initially adapted to a 10-session version of the treatment that still, incorporated many of the same key elements of treatment, but also incorporated some new activities and content that were identified through the qualitative interviews. We also have a coaching component with with another school professional reinforces strategies from the group on a weekly basis. We saw nice findings from our case series, but we also got qualitative feedback that they wanted more. We thought we were going less for a good reason, and they wanted more. We also were conducting this group during lunch, which was going over very big. They wanted, because we were bringing in the lunch. And so I think our program officer thinks this whole thing works because of the lunch, but we do give the lunch to the comparison group too. And so we actually expanded the treatment to have a didactic session and a practice session now for each content area. So it's actually longer. I don't know when people ever do that, and then it started. But we're in the midst. We were actually doing really well. We're about halfway through our randomized control trial, hoping to wrap up this year. So hopefully I'll have a little bit more to say about whether this works as compared to the normal services that they provide in the School Health Initiative in the months and year ahead. But that's really it. That's, I think that's about all that I'm going to say today. I do think that I kind of started my research journey to kind of answer a question about whether transdiagnostic approaches like the UPC or UPA could aid in providing more effective treatment than single domain or diagnosis programs for youth. And I think to a certain extent, one could argue that the base treatment we have provides similar rates of efficacy to those types of approaches, of single domain disorder approaches, and that the answer to further advancing beyond this point might lie in the contextually driven, personalized adaptations, like some of the ones that I've shown you, like UPeace, or accessing via single session interventions or digital interventions. But I mean, maybe it's because I wrote it in the first place, but I do think that the UPC and UPA based model has value too, particularly as a learning tool, which is what a lot of people have told me kind of again and again, that learning sort of broadly applicable cognitive behavioral strategies for youth also has an important training function. And there may be some scale up limitations in creating so many different versions of this treatment, or assuming that significant adaptation modification is always needed. For example, there was a recent study that just found that the existing UPA model was more acceptable and potentially efficacious regarding COVID-related PTSD, which still is kind of like blowing my mind, versus TFCBT. And of course, that research needs a bigger effectiveness trial to understand better, and also in a non-COVID sort of space. But I do spend a good deal of my time training and supporting implementation of these approaches. And I think as we continue to pursue these more implementation-oriented aims, in addition to updating our existing sort of base intervention, I think the long-term future is going to be really about making sure that there's access to good approaches like these around the world. So thank you. And I always have to thank my team because they actually do all of the work that you just saw here. I do none of it. So I just wanted to acknowledge my beautiful team. This is actually a picture from across the street from our office at the University of Miami. So it's a very ugly place, as you can see. And so thank you, and I'll stop there.
Thank you very much, Jill. That was great. As we typically do, please raise the hand little figure on Teams if you want to ask a question. And I'll ask, looks like we have a couple. Natalie can go first.
Hi, thank you so much for this talk. It was really awesome. So for some context, I'm a doctoral student in school psych at UConn, and I actually work in Golda's lab.
Oh my gosh.
So your UP study, I'm just interested because in some of the stuff we're doing with Golda, we're looking at if like nurses or other school
Mhm.
staff members can implement some of these interventions. So I was wondering if you have plans to look at if anyone other than like mental health professionals can implement, or if it's just strictly mental health professionals.
It's a great question. You know, when we were originally ready, I will tell you, IES, who funds that study, had that question repeatedly when we were getting reviewed. I think that the challenge was really the setting itself, the school health setting that we were working with did not want the nurses to be the providers. I think they felt like their nurses were really overtaxed in sort of the physical health space, and they hadn't been sort of hiring with the idea that the nurses would be the providers of any mental health services in mind. So we got a lot of resistance from our team with the suggestion that also the IES reviewers also had. So in this study, no. But I think that when we think about scale up, because the whole point of doing this is that eventually you go from these sort of treatment development studies to, trying to scale up outside of just your local county where you're doing this study. I think thinking about this setting worked for a reason. Can we leverage this type of setting with the types of providers who are there more typically, is one option for scale up that we've thought about. And then we've just thought about the partnership piece in general being really important, and that landing with a group that has trust in that particular county to be the provider of such services, whether those are nurses, whether those are other types of mental health providers, might be an important other question we could be asking, subsequent to this one. So I think it's a good question.
Thank you.
Thanks, Jill. Julie?
Yeah, really nice presentation, such an impressive body of work. So kudos to you and your team. I think, since John Weiss's book has come out and your work, like I think about teaching my graduate level child therapy class very differently than I did, 5-10 years ago. But I want to hear your recommendations. I don't know if you teach that level course.
I do teach that class.
Yeah. So one, would you share your syllabus? And then two, but just, the ways you have thought about teaching it these days, given the sort of change in the way we think about treatment work.
Yeah, I think that you're landing on something really important, which is, I think back in the day, we would just teach us based on like a problem specific set of approaches. Like today we're going to do treatments for depression, tomorrow we're going to do treatments for ADHD, and so on and so forth. So I do a little bit of that still, but I do also run I have one day where we do a flipped methodology where they do kind of sort of inspiration from sort of the Mary Freystead paper, where she talked about sort of doing a flipped method where they kind of watch the videos from the Center for Children and Families, like kind of their speaker series, in addition to which some of you I think have been presenters in, and then in addition, and then we spend the time kind of discussing the literature on a particular topic each week. But then in our other class, I run a role play group for the UPC and UPA. So we really just dig in, and I've done it with we've done a behavioral parent training group, we've done match, we've done, because I was like, oh, you don't have to learn my treatment. But I think that it actually has worked best when I focus on the one that I know best, and really like being able to dig in on the role play piece. So that's what we're doing now. I'm happy to send you my syllabus. Yeah.
Okay, good. Yeah, I'll send you mine too, and we'll swap stories.
It was funny. I was just updating it last night.
Yeah.
So.
Thanks.
I happen to teach it this fall.
Thanks, Jill. Hannah?
Yeah, so I'm really curious about some of the kind of training and implementation in community settings, and if or how you see clinician attitudes towards manualized treatment or behavioral strategies kind of plays a role in their uptake of the UPA and UPC.
I think people are going to do what they're going to do, and they're sometimes comfortable with behavioral strategies, and they're sometimes not, and sometimes that's experiential, right? So maybe they get a little bit of supported practice, in teaching kids how to experience bravery in new settings and new situations, and they get excited about it because it like works so well that they keep wanting to do it. And then some people, I always go back to the quote that Michelle Krask has, where she's like, exposure therapy is exposure for clinicians too. There are going to be some clinicians who don't want to do that exposure therapy or don't find it beneficial enough to do that work. And, I think what we've sort of tried to do as much as possible is understand, and that's what we're kind of getting into now. A lot, I didn't really talk as much about our like in-house mechanistic research that we were doing, but we're really trying to understand how different aspects of the treatment affect change and when they affect change, and like, do we need the caregiver components? Do we not need the caregiver components? Does it matter if somebody does exposure, if they don't do exposure? I mean, some of those questions we think we know the answers to. But when you have a modular, flexible treatment where sometimes people are choosing different things, trying to answer that question can become complex. So I think, long story short, when it comes to the practitioners, we really try to emphasize, when I train people, I usually say, like, try to do the whole thing with two cases and then come back to me. You know what I mean? Like, if I can get you to do 2 cases and you're still like, I hate this, or I hate this aspect, then I'm okay. I understand. It's maybe not for everybody, or maybe you like this other approach better, or you like fusing it with this other approach. I had a clinician in the COMET trial who would only join with me if she could combine TFCBT and the UPA together with her cases, because she really felt like, understandably, that one was a kind of more proven trauma-informed approach. And so I said, okay, so do it, let's bring them together. Let's co-create together, what we're doing. I think trying to, there are some people who will say, if you're not doing aspects of the modality, you're not doing the modality. But that's not what I say. So I'm, again, more of a pragmatist, and I like people to use any evidence-based strategies that they're willing to do.
Thanks. Eric?
3 things. One, I'm a pragmatist too. I've had the exact same conversation or argument with John Abramowitz about EMDR. I'm like, yeah, it costs more. It's a slick branding thing, but it works. It's better than them not doing something that works. Yeah. The other, wow, great talk. Every time I've heard you talk, I'm like, dang, you're doing a lot and you're working with a ton of people. I have your slides look beautiful.
Oh,
I'm looking at your slides and I'm like, my slides don't look that good. And and with the group, we've talked about feeling like an imposter, and I'm not saying that you make me feel like an imposter, but I have a friend. But I have a friend that might be like, oh, I might know someone who might be intimidated by how beautiful the slides looked and impressive the program of research. But here's the question. Imagine that you were working at a large research hospital and trying to think about how to really help a lot of children and families. Yeah. Are there any people that are doing a good job already of thinking about modular treatments or transdiagnostic treatments and getting them implemented into a system of care? Or do you know anyone that would like to work with someone who thinks a lot about evidence-based assessment and would like to try to plug that into a place with a large system of care, mashing up like EBA and transdiagnostic stuff?
Right, which seems to be like I said, they seem to work nicely together, and not better or not worse necessarily than just using that was the YOQ that we used in the COMET study. so we partnered before with a few different places to do the treatment at scale in their system. So Lurie is one of them. We're just working right now with Children's Hospital of Atlanta. Amita Health, has also, and most of the time when we've done that kind of scale up work, we've tried to think really systematically about all of the key pieces, right? The training, the ongoing training, the supervisory support for new people coming into the system. They have embedded in the EMRs as well. We have pretty systematic kind of fidelity-based notes, so to speak, to try to make sure that people are identifying what they used from the treatment. And we use the top problems assessment, similar to John Weiss's treatment, to have sort of and some proprietary, really short anxiety and depression measures that we give every week to try to sort of inform a kind of self-evaluation of how the treatment's going on a week-to-week basis with your supervisors. Not quite obviously a measurement-based care model, but something small to provide some idiographic data on a week-to-week basis.
Oh, neat.
Yeah.
And are those Epic shops or Aspire shops or Titanium?
Epic. Yeah, I mean, we use Titanium in our own clinic, and I mean, our training clinic, not my research clinic. We just use RedCap for everything in my research clinic, which makes it a lot easier to do it exactly the way you want to do it. But it's funny because I hadn't really thought to try to do it in Titanium because I find Titanium a little wonky.
I have thought about it, and I agree. Downvote it.
Yeah. I mean, every time I try to log in, I find it wonky whenever I sign a note. But anyway, regardless, I don't think we've got it down to a perfect science. And I think that there are definitely improvements that I would make, every time we kind of go through this with a new hospital or agency to try to help with sustainability in particular. And again, I think that people really they like this type of a model, or, like John Weiss's New First model, because they are flexible and because they really do sort of allow some a little bit more leeway for, clinicians to both be kind of like learning a base model to use, but also to sort of say week to week, okay, but I supplemented with this, or I varied it, or I skipped this and went to this other thing instead. And, that's totally fine, within this type of a model. But we're not giving, like, as they do with Match, like a lot of algorithmic sort of ways to go, which I think has a value, but maybe is very complex to track also. So, I think it's worked so far for the hospitals that have incorporated it, seem to still be using it. So that's good.
That's a win.
As far as I know, we haven't been de-implemented, from the sites that we've worked with in the last 5 to 10 years.
Thanks.
Very, very cool.
Or maybe they just wouldn't tell me.
Yeah. I have a question.
Like all of our therapy dropouts.
Right, exactly. I'll just fade away.
So I'm not an anxiety treatment expert by any means, but and a lot of my training came on internship with Sam Turner and Debbie Bidell at WIPIC. And
yeah,
I took away from that how critical the exposure piece is. Like, if you're taking anxiety treatment apart, that's one you'd want to rely on heavily, even if you don't use all the parts.
Yeah.
However, in schools and clinics where I've worked over the years, it's the one most often rejected in terms of parts of CBT for anxiety. And some of it, I think, has been misinformation. Like, some clinicians swear it's cruel because it re-traumatizes children, and other people are just uncomfortable making children feel uncomfortable. And it's kind of unfortunate because school provides a better setting to do exposure than almost anywhere else you could be, because there's socially difficult situations, there's performance difficult situations, there's all kinds of situations that for which exposure would be perfect. I assume you've run up against this, and if so, what are some of the techniques you've used to address the lack of comfort of doing exposure? You
Well,
should do exposure for exposure.
Well, I think that there's a lot of answers to that question. A former student of Mandy's and mine, Emily Becker Hames, has been doing a lot of great work to try to, demystify and kind of rebrand exposure therapy in ways that feel, more like talking about it as bravery practice, for example, versus, and also she has amazing resources on her website that are just freely available for people to learn and access, the hard parts, which are like coming up with the ideas for exposure and things like that. So I actually partner with her resource a lot in terms of just this anxiety toolkit that she has online. And I think that, but aside from sort of overt tools like that, I see I just started working in schools, really. Well, I didn't. Way back when I started as like an undergrad, I was working in schools, but came back to it now more recently. It kind of feels like home a little bit. And it's interesting observing it in this trial, because our initial thought had been that we would teach these coaches to be exposure coaches, and that they would practice these strategies, in context with the kids. But immediately we got pushback on that and most of these are guidance counselors, some are trust counselors, some different roles in different places in different schools. And it wasn't so much that they didn't want to do it, they didn't understand how to do it. So that was one piece. But the other was they didn't feel like they had time. And I do think that that time piece has come up as the barrier more than anything for doing it in schools. We feel it too, because we do it in the group, but we've only got the 40 minutes of lunch. Right. So, but like good exposure rules are, you don't start an exposure you can't finish, right? Like, or you can't like bring to some positive conclusion. So we have to make decisions kind of on the fly of, can we actually do this exposure now with these kids? If not, if I sign it for homework, will they actually practice it? Because the coach doesn't really understand the exposures, even though we've tried. We've kind of reverted to just like a review function for the coaches. So we've been thinking about this with we're putting in another version of this grant to IES right now, and well, maybe right now if I get the grant done, but I hate IES's deadlines. But we're thinking about also peers here maybe being a possible support for exposure practice in the schools. And now we have a whole group of very enthusiastic champions from the high schools who are wearing our t-shirts and are very into the treatment. And so we're well, maybe we could leverage these peers who now understand what exposure is, because they did it in their own groups, to maybe be partners with the newer, younger kids that we're wanting to recruit from the middle schools. So I don't know that that's an answer that's going to disseminate broadly, but I do think that I see the challenge. I see the challenge specifically in schools. And I think it's a challenge worth thinking through, because you're absolutely right, Steve. If we can figure it out, right, then that has some very big importance to the dissemination of these practices. Obviously, we're in the best treatment setting for kids.
Yeah, thank you. I found that difficult when I've tried to encourage its use. It's not just schools, but even with clinic-based clinicians, it just doesn't feel good to them. They want to make people feel better without having to pay a cost along the way. But
no
anyway.
Pain, no gain.
Yeah, there you go. You could call it that. All right. Anybody else have a question?
At what point did you become so awesome?
Eric, stop it. You're making me blush. We all have imposter syndrome. I think that, doesn't matter where you are. I was just ABCD president. I don't feel like, and then I go with like, I think that I'm like doing a good job in my field. I like negatively still self-compare to other people, in my same stage and field. I think it's, it's something about the academic world, perhaps, that we never sort of see ourselves as fully successful in the field, which is not a great sell for academia. But I appreciate you saying that. And it's nice that maybe other people think that, but I think maybe we're always striving. Maybe that's part of the desire to do research, is that you never kind of see it as done, or you never see it as like there yet, or ways that it could always be improved. And maybe that's why we all feel this way.
Two thoughts that you just made pop for me. I want you to have the last word, but my wife knew me as an undergrad, and she had to decide whether to wait for me as she was thinking about applying to grad school or the next thing. And she said, Eric, I love you. You're a lot of fun, but I don't think you're marriage material, because I've never seen you work hard. I'm like, I could. And then in grad school, pretty quickly, it stopped being about the grade and started being about, hey, the more that I grow, the more that I level up, the better the research I can do, the more that I could help people. And that was flipping a switch in my head. And then her question was like, can you turn it off? Can you show me a little balance, and then I'll get married to you. So those of us that are picking to go into research are sort of the ones that I think are really good at it, are the ones that are embracing there's a really important problem here, and we're probably not going to solve it in any of our careers, but if we can move the ball, is huge. The other thing, which Andy, we had a wonderful FDF here. You were here in spirit, even if, and at the end, like one of the big things, a bunch of the breakout sessions and workshops were about the imposter syndrome, which is why it's very much on all of our mind, even more than usual. And I thought about it, and I'm like, yeah, I'm in a new place, new role. I'm definitely feeling it. And I asked how many people had seen The Shawshank Redemption, and the line, get busy living or get busy dying. If you're staying in your comfort zone, you're not growing, you're stagnating. And like, every time that I hear you talk about yourself, you're adding something new, you're trying something different. So it's not surprising that you feel like you're out of your comfort zone, because you're growing and challenging yourself, and that's why you're so cool.
Thanks, Eric. That was very nice. Yeah, I just presented in front of a bunch of implementation scientists the other day, and that was uncomfortable. So I hear you. I think that, you're right, is the more we push ourselves to kind of grow the field and grow the work, the more uncomfortable it is. So I appreciate that perspective. Thanks.
Well, thanks to you, Jill. I appreciate you doing this. I know we all do.